Okay, so it's time for our Q&A session. And as a reminder, you can ask a question or make a comment by typing it in the chat box. And we definitely have a few questions that came in, a couple that came in during Dr. Wang's presentation that I'm hoping maybe you all can answer for us, doctors. One is specific to, well, there's actually two specific to existing data and or clinical trials being developed for MRD regarding the RUNX1 mutation, if there's any existing data or clinical trials being developed for the RUNX1 mutation. Does anyone know if there are?
I'm not aware of any specifically targeted agents. And one of the questions here was regarding MRD for RUNX1. I think, some RUNX1 aberrations are mutations, and those would probably need to be picked up by a PCR assay or a next generation sequencing panel. Many centers probably do not have specific PCR for RUNX1, but maybe some of my colleagues have other thoughts about that. And some RUNX1 aberrations are parts of translocations, for example, the 821 translocation, and those could be picked up by FISH or routine karyotyping.
Okay. Thank you, Dr. Leesveld.
I would have to second that and say that I don't know about any kind of targeted therapies specific to RUNX1, in part because it's a transcription factor and it's hard to target. And I think that it's kind of been mentioned in different publications in terms of a different approach to treatment, such as immunotherapy, and perhaps having a unique immune profile that then can be the focus of the strategy as opposed to RUNX1 itself.
Okay. Okay. One question back to MRD is, someone asked if you could go over the 4 MRD test options and explain in simple terms what the 4 are. Anyone want to take that one?
Yeah, go ahead, Lourdes.
I could just start. So the most commonly discussed ones are flow cytometry, and there's a difficult word that's used with that, which is multi-parameter. Just refers to the fact that the technique is anchoring on different surface markers, like different proteins, just markers are on the surface of the cell. So that one came to us in AML from, I would say, ALL, and where there's a lot of experience with it. And then that's probably followed by PCR. Different kinds of PCR is really the second kind of major technique used to track or detect measurable residual disease. And then I believe Dr. Wang mentioned next generation sequencing as a third kind of technique to, for detection, because it has the possibility in part of picking up multiple mutations at once. And then the fourth I don't recall a fourth technique. Maybe one of the other panelists does recall. She did touch upon the fact that it's more powerful to use more than one technique at a time. So
I'm not sure if she mentioned digital droplet PCR as well. But, though that as well as NGS, I think are still in the early stages of being really validated, to make sure we're increasing sensitivity and things like that.
And one of the things that she showed was that on the topic of sensitivity, it depends on the technique as to how sensitive the technology is. So multi-parameter, this flow cytometry, this detecting the surface markers of leukemia cell, for example, is typically less sensitive than using something like one of the newest technologies for PCR. So, I think there is some controversy still around how sensitive the technology needs to be, and where to set the threshold for measurable residual disease. These are very difficult names.
Okay.
It never helps.
Okay, well, thank you for trying to answer that one. And this is also on MRD is, does MRD show up before relapse post-transplant? So can you see the relapse coming, I guess?
I think that it depends on the biology of the disease and the sensitivity of the test that's being used and whether or not it's one test or a combination of tests. So in the ideal setting, we would want to see, for lack of better terms, the train coming, with a more sensitive test building. But some patients may have a more aggressive disease biology, and we're not able to pick that up before it presents clinically.
Okay. And how often, and I feel like Dr. Wang might have covered this, but how often, if you're in the so-called, remission, or how often are you doing MRD testing if you're in remission after a transplant?
Usually, oh, please.
Go ahead.
Kareth, were you saying just in this general scenario of remission, right?
Yeah.
It can be according to treatment milestones. So for example, after you've completed induction and attained the first remission, after completing a cycle of consolidation, a second cycle of consolidation, or before and after transplant, or it can be by time, and not, according, let's say you're in a surveillance or maintenance phase, and then every 3 months is a typical time frame.
Okay.
And I think many centers would, if someone's been in remission for 2 years, that might space out further, but there's really little data to guide us about that.
Okay. Okay. Thank you. I think this is a good question. Comment. The clinical trial process is extremely cumbersome. Are there any suggestions you can offer for someone, just basic tips to help, when you're going through that process, or how to make that process a little bit easier?
Yes,
From the get-go.
Yeah, that's a great question, because I think it is sometimes overwhelming when you're presented with a 15-page consent form to read and a chart that lists all these tests and visits that are required for the clinical trial. And as was mentioned in the poser of this question, certainly one's physician can help, I think, guide through that. And many centers do have a research nurse or a clinical trial coordinator that really should be able to work with the individual patient and their caregivers or families to understand, what that sequence of events is going to be, what to expect. And certainly that doesn't take away all the cumbersomeness, but I think it really can help people to navigate the system. Some centers have even what's called a nurse navigator that even, I think, physically helps patients get from point to point of where they need to be in this testing and the clinical trials process. But at each center that will be dealt with, I think, a little bit differently, but there hopefully will always be those supports and people to reach out to or to ask questions of if there is, kind of a burden that's going with the clinical trial.
Okay, thank you, Dr. Leesveld. I think this is an important question and one that probably we still have a lot to learn about. This is, do you have any information about CAR T cell therapy for relapsed AML?
I think many of the trials that are underway with CAR T therapy for AML are still very early. Most of those are being, as I understand it, looked at in a relapsed refractory situation, because we still, I don't think, have really established the right target that isn't going to lead to prolonged cytopenias in AML. So many antigens that are targeted are also expressed on normal hematopoietic stem cells. At our center, we don't have any of these trials open right now. I don't know if Dr. Mendez or Dr. Prespoleski have other thoughts about that either, but it's certainly an exciting area. There are ways that these constructs are being changed to, perhaps make these more effective in AML without, completely wiping out normal stem cells, but there's still a lot of work to be done here.
Okay, thank you, Dr. Leesveld. And let's see, we have a couple more questions. We have a couple more minutes. So there was a comment, and I believe Dr. Wang covered this, that she spoke briefly about maintenance of venetoclax and azacitidine. One of our caregivers, she says her daughter relapsed after transplant by about 5 months, even with maintenance of venetoclax and azacitidine. And I believe her daughter is a young adult with inversion 3, monosomy 7, MECOM/RPN1, and also GATA2. So that one sounds complex.
Yes, I think despite maintenance, unfortunately, some patients still relapse, and after relapse after maintenance, there are many different options that can be discussed. I think, as was mentioned, the patient's performance status, their history of prior therapies, how quickly the relapse occurred, and how aggressive that relapse was, will all influence what can then later be offered after that time. So even sometimes when we have patients who are MRD negative and we put them on a maintenance, that relapse, unfortunately, in this disease can still occur. And that's one of the reasons that all these clinical trials, we hope, will give us some answers for the future.
Yes.
And as was mentioned, in a situation such as this, where the standard of care, one has basically, kind of moved beyond that, it's so important to have, if possible, if, appropriate, a positive disposition towards clinical trials, where a new approach is really needed for what is, clearly a tough disease, as the inversion 3 AMLs are known to be.
Okay, thank you both for that. Okay, so it's 10:30. I do have one more quick question that I think is an important one, because I think a lot of people ask about it. There's the use of marijuana to help with pain and or anxiety. And I think it's important to hear from doctors, and there may be differing opinions. So if someone could just speak to this briefly, and then we'll end on that.
I suppose I should take a stab at it, since it was my topic. So I think, it's important to be open to what could help someone, and, in different ways, right? Because support and relief comes in different ways. To my knowledge, there isn't anything like that's like in the way of published studies that we can anchor on as professionals, which is, one of our responsibilities to try and kind of base our practice and recommendations, if possible, on published information. That doesn't mean that it, can't be good and helpful. And in the case of, what's specifically being asked about, which is marijuana, I think not specific to, this situation, but in all situations, there's probably, and, actually like all our tools, there's possible risks and possible benefits that are worth a discussion and a very kind of like being open and frank about. And so, I think it could have a role, but you want to discuss also the fact that there can be an infection risk there. There can be a worry about, invasive fungal pneumonia, which our patient population is particularly, vulnerable to. And then you have to weigh, are you willing to take that risk if it may preclude, other options, if for example, we're talking about treatment and not just palliative measures. So I think I'll pause and see if anyone else has things to add. So I believe I should say that I think if even in the situation where marijuana is consumed, not inhaled, that risk is not fully eliminated, to my knowledge. But I'll pause there.